Thank you. You ready? So I'm Warren Luce, and I'm really excited about what we're going to talk about over the next 2 hours. That was my introduction. All right, so today we're going to talk about the function of vitamins 1 and 2. Really, the whole discussion of vitamins could come in sort of at the beginning, like what we're doing, or the very end of biochemistry, and certainly you will expand on this story as you go through biochemistry and or other subjects. Nutrition, and in particular the vitamins, are a topic that are heavily tested on board exams, so it's good to start learning this stuff now. This is high yield stuff for boards. And the way that I'm going to approach it, I'm trying to give you the high yield facts, okay? So, and in cases where we need to dive in a little deeper and do some explanation, we're going to do that. So for certain vitamins, the story is a lot longer than other vitamins, as you're going to see. In a general rule, I'm not going to read through all the learning objectives with you, but that very first statement holds true for all of the vitamins we're going to talk about. So for each vitamin, you want to know what the function of the vitamin is. That's the very first thing. And we're going to tell you the function of all of the vitamins. Now, we don't always have good symptoms of a deficiency. Some we have very clear-cut, very well-defined disease when you have a deficiency. In some of them, it's not so clear-cut, and in some of them, the deficiency is so rare that it's practically never seen, and the symptoms are not very specific. So when you see things like that, don't get worried. The Comlex or me or USMLE or anything like that, it's not going to expect you to be able to know any more information than what we're able to provide. Okay, so therefore, you'll see when I spend a lot of time on a certain vitamin or vitamins, or the stuff I'm really emphasizing is the high yield stuff. When we get to vitamins where we don't really know a lot about a deficiency, for example, just when we get to those, more or less focus on what the function of that vitamin actually is. And there are a few vitamins. There's one water-soluble vitamin and two fat-soluble vitamins. All the fat-soluble vitamins could, in theory, be toxic in excess, but two of them are particularly notorious. Okay, and then the rest of those are kind of specific. So basically, the way we're going to break down this next two lectures is the first lecture I'm going to talk to you about the water-soluble vitamins. In the next lecture, we're going to talk about the fat-soluble vitamins. There's actually much fewer fat-soluble vitamins, but the story is a little longer because two of them take a little while to explain. So first of all, what is a vitamin? And a vitamin is going to be different depending on what organism we're talking about, because a vitamin is a compound that cannot be synthesized in adequate quantities. So what's a vitamin to you may not be a vitamin to something else. Okay, a good example is vitamin C. You can't synthesize vitamin C, or at least not in sufficient quantities. And so other organisms can synthesize vitamin C, so to them it's not a vitamin. So a vitamin is something you have to get in your diet. It is a micronutrient of some sort. In some cases, in some of the vitamins we can make it, we just can't make enough. Or in the case when we get to vitamin D, it depends on what conditions you're in, whether really you would consider it a vitamin or not. But that's the basic definition of a vitamin. And they are broken down into water-soluble and fat-soluble vitamins. Okay? Water-soluble, as its name implies, is soluble in water, so they are excreted in the urine, or can be excreted in the urine. So that's our B vitamins and vitamin C. We'll talk about all of them today. So therefore, you don't really usually see toxicity associated with excess. So out of all those B vitamins and vitamin C that we're going to talk about, only one of them is known to cause serious symptoms in excess. And you have to really get an extreme excess. So you really have to be supplementing in order to see an excess of that vitamin, and I'll get to that shortly. But because they're water soluble, for many of these vitamins, the deficiencies can occur quickly. So with the fat soluble vitamins, you can really store them. With some of the water soluble vitamins, we'll store a fairly significant quantity of them, but in many cases, we don't store much, if any, and you really have to get the vitamin pretty much every day. Our fat-soluble vitamins are A, D, E, and K. So if you know the fat-soluble vitamins, then you automatically know everything else is water-soluble. So there's only 4 fat-soluble vitamins. So I think in one of it's probably in the next set of objectives, it says which are the water-soluble vitamins. So know that, and then you know the other ones. And there's a particular reason to know that. So the fat-soluble vitamins are going to be transported, absorbed, and released with dietary fats. So in some cases, that can help you figure out where you're going to see a deficiency of those vitamins. Anything that's going to interfere with the transport, absorption, or release of dietary fat could cause a deficiency of these fat-soluble vitamins. Toxicity is much more common with fat-soluble vitamins. It's relatively easy to get an overdose of vitamin A and vitamin D, for instance. With the one fat-soluble vitamin the one water-soluble vitamin, which is going to be B6, where you can actually get an excess where it's toxic, you really have to get a very extreme excess. With A and D, it's not really that much more than the recommended daily allowance. Like, let's say just one order of magnitude more would be toxic. Okay. And there's a little chart. It's got all of them on there, and let me just make sure. Yep, we're going to talk about all of them. All of these right here, it looks like 3 different vitamins, but that's all vitamin B6. So that's a nice little chart that you can use to kind of remember. And it divides them up into what they're doing in real general terms, and we're going to go into the specifics of what their function is. So the first, and you'll notice in the water-soluble vitamins, especially if you've already went through this PowerPoint, you'll notice that probably maybe 2/3 of this lecture is on folate and B12. Okay, that's the most important part of the story, and the hardest to understand. It's not bad, and it's also the most critical to understand, the most high yield. So we're going to spend quite a bit of time on folate and B12. So folate, key role in 1-carbon metabolism. That's its job. Where do you see what do I mean by 1-carbon metabolism? Either we're adding or removing a carbon from something, so we're building something or breaking something down, but that's its job. So it binds temporarily some carbon-based group and can transfer that group. So it can remove it from one thing and transfer it to another thing. And where you really see this used quite frequently is nucleotide synthesis. So that's going to be a key thing, and amino acid synthesis. So if it has a role in nucleotide synthesis, then what's going to happen if you don't have enough folate? What aren't you going to make? You can get amino acids from your diet pretty much, so that's not quite as critical. But nucleotides, you have to synthesize. So you can have a deficiency in nucleotides, and then, okay, well, what's going to happen because of that? So think about that, and we'll talk about that. Probably the most common vitamin deficiency in the United States. We say probably. It's a hard thing to define. And in many cases where you're going to see a deficiency in folate, first of all, it can be masked in multiple deficiencies, because one of the most common places you see it is in alcoholism, which alcoholics tend to be deficient in many vitamins, not just folate. And one really important one we're going to talk about a little bit later on that has some of the big symptoms of alcoholism. But so that's where, so sometimes it's hard to figure out exactly what deficiency we're talking about, or in many cases, this patient might not actually get diagnosed, but we think it's the most common vitamin deficiency. Another place where you can really see folate deficiency is in pregnancy. Okay, and this is going to be, there's going to be a key fact about the amount of folate in the diet that board exams are going to expect you to know. I pulled this figure out of your textbook, and it included a little bit extra information. But this is a drug we're going to see, methotrexate. It actually inhibits dihydrofolate reductase, and yeah, I do think, at this point you can start learning this, the drug and the enzyme, because this is one of those you're going to see over and over and over again. Okay, so it inhibits the formation of THF, therefore inhibits the synthesis of nucleotides. So this is a drug we can use. It's really a chemotherapeutic, so one of the places you'll see it used is to treat certain types of cancer. You'll see in there they have a couple autoimmune diseases, but it's the same idea. You're trying to interrupt fastly dividing cells, okay, by inhibiting nucleotides. You inhibit the synthesis of nucleotides, you inhibit DNA replication, you slow down rapidly dividing cells, including cancer. So what are the symptoms of a folate deficiency? One of the biggest symptoms of a folate deficiency is going to be a macrocytic or a megaloblastic anemia. So megaloblast is a large, immature red blood cell precursor. So what's ultimately going to be a red blood cell? So what happens in this case is if you have a folate deficiency, can't make nucleotides efficiently, the cell gets ready as if it's going to divide, so it does all the things it needs to divide, but it can't completely synthesize its DNA, so it just gets bigger and bigger, and then it kind of gets in a stage where it's ready to divide, but the DNA hasn't replicated, so that's what a megaloblast is. Okay, so there's some other anemias here, including some we're going to talk about today. Iron deficiency anemia is going to be your most common anemia, and it's a microcytic anemia, but we're really not going to talk about iron today, but it's a good high yield fact to know that iron deficiency anemia is your most common anemia. Before the end of med school, you will know, hopefully, when you go to take your boards, you're going to know more about anemias than you ever thought possible. And certainly Dr. Siddiqui does an awesome job getting you ready in that regard. So you'll talk about some of that stuff. Peroxidine, that's B6. Ascorbate, that's vitamin C. Those both cause a microcytic anemia. We'll talk about those ones today. But B12 and folate cause a megaloblastic anemia. Okay, so I just told you what a megaloblast is. The daily requirement is about 100 micrograms or 0.1 milligrams. That's how much an average person would need. You do store folate. Actually, you store folate and you store B12. So those are two that you do have somewhat of a store, even though they're water soluble. You store about 10 milligrams. So if you work out the math, that's about 100 times what you need. So we have about a 3 to 4 month supply under normal circumstances. If you're pregnant, that supply goes down because you have a little parasite inside you, which is doing what? Rapidly dividing, and it's taking up all of your folate, okay? An average Western diet, so the average diet in the United States is about 250 micrograms of folate a day, so you'll notice about 2.5 times what you even need. Okay, so under a normal diet, folate deficiency is not an issue, although for pregnant women, that's really not enough folate, so they actually recommend you supplement. So first of all, what's going on, I just mentioned in a pregnant woman, you have a fetus which is rapidly dividing cells, so they're using up the folate stores. And what happens in in the fetus, if there is not enough folate, is there's the neural tube defect. So this is one of the things that's absolutely been proven. In many cases, you're going to find information on the net, or you've maybe heard, or sometimes even in biochem books, where they recommend, okay, if you have this condition, go ahead and supplement with, let's say, vitamin C. In many cases, they know it's not going to hurt, but they're not exactly sure if it helps or not. But this is one thing that's been very well established. They know that if you supplement with folate before conception and during the first trimester in particularly, it's actually going to significantly reduce the incidence of neural tube defects. Okay, and I've shown you a picture of the two most common ones, spina bifida and anencephaly. So basically, you're missing your head right here. So those are the most common neural tube defects. Supplementing with folate has been shown to significantly reduce the incidence of these. So for all pregnant women, they're actually going to recommend you get at least 0.4 milligrams or 400 micrograms of folate daily. And the COMLEX does expect you to actually know that number. Okay? So that's fair game for them to test you on that. Therefore, because they expect it, I'm going to expect you to know that number as well. Okay, so I already told you one of the big symptoms you see with a folate deficiency is a megaloblastic anemia. Okay, you see a megaloblastic anemia, that's one of the things you should be thinking of. Folate deficiency could be cause of the megaloblastic anemia. Another thing that folate deficiency causes is an elevated level of homocysteine. So we have this little reaction here, homocysteine to methionine. Now you've heard of methionine, right? That's one of our amino acids. You probably haven't heard of homocysteine yet, have you? I don't think. See lots of no's, so I don't think you've heard of it. So homocysteine is one of many compounds that can actually react with LDLs. And I don't think you've probably had the story of LDLs yet. But LDLs, just to keep it real simple right now, because we're going to talk about them in much more depth a little bit later. Basically, that's our bad cholesterol. You've got these lipoprotein complexes floating around in your bloodstream. If they get damaged, they're going to cause plaques in your arteries, okay? And one of the things that can damage them is homocysteine. You can also get some oxidation, you can get chemicals from smoke. If you have high blood sugar, you can actually damage them. There's a lot of things that can damage them, a lot of things that can cause cardiovascular disease, but homocysteine is one of them. If you get elevated levels of homocysteine, if you have homocysteinemia, then you will cause a cardiovascular disease, okay? And if you have a folate deficiency, because you're going to prevent this reaction from occurring, you will build up homocysteine. So that's another effect. You get your megaloblastic anemia, and ultimately you can end up with cardiovascular disease, in particular if this is a chronic issue. So cardiovascular disease typically takes a while to develop, but certainly if you have chronically elevated levels of homocysteine, that's going to happen. Now, here's our first intersection where, okay, so we're talking about folate, but you can also see vitamin B12 is in this same reaction. We're using folate and we're using vitamin B12. So we're going to have a little bit of an intersection here. So insufficient B12 can also cause elevated levels of homocysteine. So one of the symptoms of a B12 deficiency can be cardiovascular disease. Okay, so elevated levels of homocysteine react with LDLs, end up causing plaques. Okay. Now you'll notice this conversion of homocysteine to methionine makes tetrahydrofolate. Tetrahydrofolate is the active form of folate. Now there's actually multiple, so tetrahydrofolate is sort of the naked active form of folate. So it doesn't yet have the carbon group that it's going to transfer. In this case, this N5 has a carbon group on it. Okay, so, but we need this reaction to actually regenerate tetrahydrofolate. Okay, now that's going to become important shortly. Only 2 reactions in your body actually use B12. This is one of them right here. So the conversion of homocysteine to methionine is one of the reactions that uses B12. Yes.
Where is the folate in A? You're saying it's like if we have a deficiency in folate, then we can't convert homocysteine to methionine, right?
That's true.
But it looks like it's a product. So where is it going into that?
Well, really, so they could have just written it on the side here like B12. Anytime you see a reaction like that, when they have vitamins and or cofactors, sometimes they'll just show them on the side, but there's always some kind of reaction going on. They were showing you this reaction in particular, because it's gonna be important for something we're going to talk about in a couple slides. But they could have just written B12 and folate on the side and just say they're required for this reaction, like they did with B12. They're not showing you exactly what's going on with B12, the actual conversion there. But whenever you have a cofactor, a vitamin cofactor in a reaction, there's something going on. Ultimately, it's going to be converted back, but there's always something going on. They don't always show you the actual reaction. So in this case, the conversion of homocysteine to methionine requires both folate and B12. Both of them are required, okay? But this particular reaction is shown in a little more detail. It looks like it's a product of the reaction. This is really the product. This is the reaction we're talking about. These are just cofactors on the side, okay? In many cases, they won't even show you what the reaction is on the side, but there's always some reaction there. Okay, so hopefully that answered your question. So the other reaction that requires B12 is this methylmalonyl-CoA mutase, which is shown right here. It catalyzes the conversion of methylmalonyl-CoA to succinyl-CoA. Those are compounds you have not seen yet, at least in this class, I don't think. You might be starting to get overwhelmed. Don't worry about that right now. We will talk about this reaction again in detail. But this is a pathway that's basically going to be involved in metabolizing, I should say catabolizing, so breakdown of odd number of chain fatty acids. Okay, and that means, therefore, you inhibit the breakdown of those odd chain fatty acids, and they accumulate, and that causes symptoms as well. Now, there are some amino acids that also go down that pathway. Okay, so I just told you a B12 deficiency, one thing it can cause is elevated levels of homocysteine. We saw that, right? Because it interferes with the breakdown of odd chain fatty acids, and these odd chain fatty acids accumulate, you're going to get some other symptoms, and that is peripheral neuropathy. Okay? And it's thought that these odd chain fatty acids accumulating in the membranes in these neural tissues, so the components of the membranes in those neural tissues are very vital to their actual function. That's where this peripheral neuropathy is going to come in. At least that's the current thought. So B12 deficiency, these weird fatty acids accumulate, they end up in the nervous tissue, you get this peripheral neuropathy. But the story of B12 and folate is going to intersect again in 1 second. But first, B12 is only synthesized by microorganisms. We don't see it in plants. So this is a clue to where you might have one possible place for seeing a B12 deficiency is in vegetarians, in particular vegans. Okay, so they have to, if you're a vegan or you know somebody who's a vegan, they have to be careful about making sure they're getting enough B12. So animals actually obtain B12 from natural bacteria flora, so you can get back B12 from the bacteria in your gut, but you also get it from animal sources. But they ultimately got the B12 from bacteria. So now you'll notice for several things in here, I gave you foods that are high in vitamins, those aren't something I expect you to memorize. Those are just FYIs, okay? Certainly if you read other sources, they may give you some other foods. Those were just in case you happen to be interested. So I'm not going to test you on what foods are high in particular vitamins. Okay, so getting back to the B12 and the folate story. So I told you you need both B12 and folate to convert homocysteine to methionine, right? So therefore, if you have a B12 deficiency, you will actually not undergo this reaction. And one of the things that can actually happen is you'll start to accumulate this N5-methyl tetrahydrofolate. So there's actually multiple active forms. So tetrahydrofolate's the naked active form. You can actually have an N10, N5N10, or an N5. So basically the carbon group that's going to get transferred can be located in several spots. Okay? If you have either one of these, the N10 or the N510, the N510 is just kind of sharing the carbon in between those two. If you have these, you can actually interconvert, no problem. If you have N5, N10, you can actually go back to N10. You can go to N5. So all of these can interconvert except when you get to the N5 form. When you have the N5 form of folate or tetrahydrofolate, it can't be converted to any other form. Okay? Why is that important? Well, if you don't undergo this reaction, you will start accumulating this N5 form. So what happens is if you have a B12 deficiency, you inhibit this reaction and you start accumulating this N5 form, which can't be converted into anything else. Then over a period of time, all of your folate starts accumulating as the N5 form. So you have a pretty good store of folate. But once again, once it gets to the N5 form, it's basically rendered useless if vitamin B12 is not there to convert it back. Okay? So what ends up happening ultimately is a B12 deficiency causes a secondary folate deficiency because it accumulates it as that. That's called the folate trap hypothesis. I've also seen it called the methyl trap hypothesis, if you've seen it written that way. So, another symptom you will see, so we talked about the peripheral neuropathy already with B12 deficiency, but another thing you will see is you'll see the same symptoms as a folate deficiency. You'll see a megaloblastic anemia. So megaloblastic anemia could be folate, could be B12. So one of the things you need to be able to do ultimately is actually differentiate between a B12 and a folate deficiency. And let me just make sure I've written that on there. Okay, yeah. So we're getting to that in a couple slides. So now the story of B12 is a little bit complicated, and we need to go through it because ultimately some of the complicated things involved in absorbing B12 can help you remember what are some of the things that causes a B12 deficiency. First of all, B12, you do have a significant store of B12 in your body. And actually, compared to the other water-soluble vitamins, this has the biggest store. So usually a B12 deficiency takes years to actually develop. Okay, if it's strictly from diet. Now, if you have some issue with some of the things we're going to talk about here in absorption, then it can actually occur quicker because you do have some enterohepatic cycling. Okay, so what that means, and you're going to see there's multiple things we go through enterohepatic cycling. So enterohepatic means we're cycling through the liver and the intestines. Okay, there's multiple things that end up coming out in the bile and getting resorbed in the intestine, and they just circle. B12 is one of them. So if you have a defect in that enterohepatic cycling, you'll get a vitamin B12 deficiency much quicker because not only will you not be able to get it from your diet, some of the stores you have you will be losing as well. So that'll actually make it go a little bit faster. So another thing, the level of methylmalonic acid. So if you go back and look at the two reactions in which you use vitamin B12 for in the body, and there is only two, if you inhibit, and let me see if I've got it on the next slide. I don't think I do. So if we go back, let's just go back right here. So if you inhibit this reaction, you're going to build up this methylmalonyl-CoA, right? So if you inhibit methylmalonyl-CoA mutase, you're going to build up this methylmalonyl-CoA. And what ends up happening is that methylmalonic acid will actually accumulate, and you can actually do a test for that. So that's one of the things you can actually use to differentiate between folate deficiency and vitamin B12 deficiency. Okay. So in a folate deficiency, this methylmalonic acid is not going to be elevated in the blood. Folate's not going to have anything to do with that reaction. And I already told you B12 causes, and we already talked about why it causes a peripheral neuropathy. The neuropsychiatric condition is because of the peripheral neuropathy. So what's going on with actually absorbing B12? Let's go through the process here because it can tell you some things of where you're going to see a B12 deficiency. So first of all, when B12 hits the stomach, usually it's associated with proteins, and the acid in the stomach will cause that to separate. So there's one thing that's involved in B12 absorption is the release of free B12 from the acidity in the stomach. What does that mean? Well, that means if you don't have that acid environment in your stomach, either because you're not producing enough acid, which can happen, and actually it's very common in older people, or you're taking something to neutralize acids or cause a decrease in production. If you have heartburn and you're taking something, you can actually affect ultimately the amount of B12 you get. Okay. Once it's in the stomach and free, it's going to bind this R protein. This R protein is, you actually can make it either in the salivary glands, it's a glycoprotein, or there are cells in the stomach which will actually synthesize it as well. But ultimately that R protein, its job is to bind that B12 and protect it. I think in one of the earlier slides, let me just check real quick. Yeah, there we go. There's a picture of B12. That's a pretty complex, therefore in my mind, sort of delicate structure, right? It's not a terribly simple thing. So you want to actually protect it from the acid environment, and that's what the R protein actually does. So then it's actually going to move to the beginning of the small intestine, so we have the ileum, and pancreatic enzymes are going to release B12 from the R protein. So it's basically going to digest that R protein. So there's another thing. Pancreas is also involved ultimately in B12 absorption. So if you have some kind of pancreatic insufficiency, you can end up with a B12 deficiency. Okay. Cystic fibrosis. Have you talked about cystic CF at all yet? Well, you will shortly, and there's certainly a good example of something where you have a pancreatic insufficiency. But anywhere where you have a pancreatic insufficiency could interfere with the absorption of B12. So in the stomach, you're also going to produce this other protein called intrinsic factor, and that's this little IF in the figure. Intrinsic factor, when it gets to the small intestine, when you release it from the R protein, it's actually going to bind to intrinsic factor. And the binding to that intrinsic factor is critical for the movement of B12 into the cells of the lumen of the intestine, so ultimately absorbing them. So IF is actually required for absorption of B12. So you can have a condition called pernicious anemia, Another example of an anemia, and ultimately it's pernicious anemia is going to be a megaloblastic anemia because it's going to be a deficiency of B12, and you have a severe lack of intrinsic factor. So this can be due to several possible reasons. A couple examples: gastric atrophy or atrophy. Also, if you get surgery to that banding surgery to make your stomach smaller, sometimes you will get this pernicious anemia. You can get autoimmune destruction of either the intrinsic factor itself or the cells that produce the intrinsic factor, those parietal cells in the stomach. All of those can cause pernicious anemia. But pernicious anemia is a lack of intrinsic factor. Okay, that's what pernicious anemia means. And as we went through, you saw other gastric or intestinal issues. So you can have, if you have stomach issues, you have intestinal issues of any sort, they could also obviously interfere with B12 absorption. Now, one of the things, and this is kind of critical to understanding everything, what's going on, folate supplementation of a B12 deficient patient can reverse the megaloblastic anemia. Okay, so if you have somebody who's deficient in B12, if you give them a whole bunch of folate, so one of the things you see in a B12 deficiency, right, is that megaloblastic anemia. Because what is it doing? Well, you end up trapping all your folate in a manner which it can't be used because you're blocking that one reaction, right? So if you dose that person with folate, you can actually, because you're giving them new folate, you can actually overcome that part of the issue. So if you have somebody who's B12 deficient, you can give them, and what you noticed was the megaloblastic anemia, you can give them a bunch of folate and you'll get rid of that megaloblastic anemia. However, you haven't really changed at all their deficiency in the vitamin B12. Therefore, they're still going to have, or still can develop anyway, the peripheral neuropathy and the other symptoms that you see, which can be very severe eventually. So when you have a patient and you have somebody who's got megaloblastic anemia, what they're going to do is, the first thing they're going to do is give them both. It's not going to hurt to give you both. But one of the things they want to do is they really want to figure out what's going on there. Is this person folate deficient or is this person B12 deficient? Because that can also tell you, okay, what might be going on or what we might look for that's causing this deficiency, right? So we do have ELISA tests for both B12 and folate, in addition to doing the methylmalonic acid test. So remember, methylmalonate or methylmalonic acid, you're only going to see that in a B12 deficiency. You won't see that in a pure folate deficiency. Okay, so does that make sense? And I realize if you haven't seen this before, you're going to have to try to get it straight in your head and then make sure you can walk through it. This is, I promise you, this is the most confusing part of the water-soluble vitamins. It's just trying to remember how B12 and folate actually intersect. Okay, so now we're going to move on to the rest of the water-soluble vitamins. First, we have vitamin C. This is one we've already seen. It's involved in hydroxylating prolyl and lysyl residues in collagen. Therefore, if you have a deficiency of it, it shows up in collagen. The first place it shows up, the collagen that gets turned over most rapidly was that in your mouth, other epithelial tissues, for example. Another thing we didn't talk about with vitamin C, there are other reactions in the body that use vitamin C we didn't look at. Dopamine to norepi is one. Also, vitamin C is important in iron absorption. So if you have a lack of vitamin C, you can cause a secondary lack of iron. And therefore, when you lack iron, what happens? You get anemia, right? So anemia could be a symptom of vitamin C deficiency. It is a water-soluble antioxidant as well. Okay, and we'll talk later on about a fat-soluble antioxidant. Once again, the good sources, that's FYI for you guys. The most common cause, that's what the MCC means, most common cause. Most common cause is a diet deficient in fruit and vegetables. So it's a dietary deficiency. And the deficiency causes scurvy. We've already seen this before: poor wound healing, easy bruising, bleeding, gums, increased bleeding time. So it's all due, all these symptoms in this particular part are due to collagen deficiency. You also can get a microcytic anemia. So this is an iron deficiency anemia because you have a defect in the iron absorption. So vitamin C will actually reduce iron so that it's effectively able to be absorbed. Generally not toxic at high doses, so just like with the other water-soluble vitamins, you can actually give a real high dose and not cause any symptoms. Now, you haven't seen glucose-6-phosphate dehydrogenase deficiency yet, so don't worry about that part. We're going to talk about that maybe next week. I can't remember exactly where it is on the schedule, but I'll talk to you about it shortly. Yes?
I've heard that high doses of vitamin C can cause an abortion in pregnant women. Is that true from literature, or?
I haven't heard that. I wouldn't say it's not true, but I haven't heard of that. So it would surprise me if it's true, but no, I haven't heard that. But it's possible. I mean, it's possible that there, and with many things. First of all, almost anything, and we should state this outright. Almost anything is toxic if you eat enough of it. So whether something is a toxin or not, sometimes that definition can vary. So, you know, like, is salt a toxin? Well, if you eat enough salt, and it's really not that much, you will die. You will absolutely die. So at certain levels, things can certainly get toxic, but I hadn't heard that. But I'll check and see if I can find anything on it after class. The vitamin C, because it's water soluble, and you don't really store it in, if you take a whole bunch of it, it'll end up in the urine and in the feces, so it can interfere with tests where you're looking at urine samples or fecal samples. Okay. And so we had already seen that. Vitamin B6, this is the only one where you can actually have a significant toxicity if you take too much of it. So vitamin B6, there's several forms. It can come in pyridoxine, pyridoxal, pyridoxamine. I just call it vitamin B6. That's a lot easier, right? There's not much difference in the structure if you look at that. But what's the function of vitamin B6? It's involved in various nitrogen metabolism pathways, so including amino acids, heme synthesis, and there's others involved in nitrogen metabolism. You don't usually see a vitamin B6 deficiency. It's very rare because it's found all over the place, so it's very rare you get a vitamin C deficiency. One of the places you can see a vitamin C deficiency is in the isoniazid treatment. This is a antibiotic used to treat tuberculosis. If I remember right, isoniazid, if you look at it, actually looks very similar to B6. That's if I remember correctly. But anyway, it can cause a B6 deficiency. So when they give isoniazid to patients, they will typically supplement with B6 as well. And speaking of pregnancy, that's one of the vitamins they'll actually advise, and you don't have to write this down, but pregnant women, they'll advise them to supplement with B6 to try to alleviate some of the nausea. I don't know exactly how that works, and I haven't seen a good explanation of how it works, but it doesn't hurt, and it seems to help. But deficiency, you're going to get epithelial changes, and this is going to be very frustrating for you guys because many of the vitamin deficiencies cause skin symptoms. So that's a very non-specific symptom. Peripheral neuropathy, you get a sideroblastic anemia, and I don't think you've seen a sideroblastic anemia yet, but there's a genetic disease that can cause a sideroblastic anemia. Lead poisoning will cause a sideroblastic anemia. This is an anemia where you have plenty of iron, but you're not making enough hemoglobin. Okay, so B6 is actually involved in the synthesis of heme. So if you don't have B6, you won't make heme. Iron will accumulate, and you'll make these sideroblasts. That's all a sideroblast is. It's a red blood cell precursor with a whole bunch of iron built up, looking for hemoglobin, basically. Only water-soluble vitamin with significant toxicity. They've never seen this toxicity just getting B6 from food, so it's when people supplement, and you really have to do a very massive, like orders of magnitude supplementation to really see this. And it causes a severe sensory neuropathy for whatever reason. I haven't seen a good explanation of what the actual mechanism is of how this actually works. But once again, most anything, if you take it in enough quantities, becomes toxic. Next vitamin, vitamin B1 or thiamine. I always just call it thiamine. This is one where you may see either name used, but thiamine is more common. TPP is the active form, thiamine pyrophosphate. It's only required for 4 enzymes in the body. Fortunately or unfortunately, depending on your point of view, those are absolutely critical enzymes. So pyruvate dehydrogenase and alpha-ketoglutarate dehydrogenase. You guys, if you studied for the MCAT or took biochem before, are probably real familiar with those enzymes, right? If not, you will be very familiar with them shortly. When I think I'm doing those lectures this year when I talk to you about those. So pyruvate dehydrogenase is leading into the TCA cycle, and alpha-ketoglutarate dehydrogenase is in the TCA cycle. One of the jobs of the TCA cycle is to produce energy, right? So if you have a thiamine deficiency, you have a defect in that. There's an enzyme transketolase. This enzyme is really not terribly important, and we'll talk about it when we get to that pathway. It's not terribly important other than this is going to be the enzyme you're going to use to diagnose vitamin or thiamine deficiency, vitamin B1 deficiency, because it's going to be found in red blood cells. The other enzymes involved that thiamine is required for aren't found in mature red blood cells. Those metabolic pathways aren't active in mature red blood cells, but this one actually is. So it provides a very convenient enzyme to measure because you can just get a blood sample. And the fourth enzyme is branched-chain alpha-keto acid dehydrogenase. Hopefully that enzyme, even though it's got a big long sounds familiar to you, that is the enzyme that is deficient in maple syrup urine disease. It also has a thiamine deficiency, or I'm sorry, a thiamine requirement. So a thiamine deficiency will cause a defect in that pathway. So you can have either a dietary deficiency or a thiamine deficiency caused by alcoholism. The dietary deficiency you don't see in the United States very often, but a dietary deficiency causes beriberi. So you have both dry and wet beriberi, and that just depends on what the symptoms are or how far they've progressed. So the dry beriberi is a peripheral neuropathy. The wet beriberi, wet because you get this edema, but that's where you get cardiac dysfunction. In the United States, the most common place to see a thiamine deficiency is in alcoholism. And thiamine deficiency caused by alcoholism causes Wernicke-Korsakoff syndrome. Okay, so it's a little bit different than a pure dietary deficiency. So what happens in alcoholics is both they have poor nutrition, so they're not getting enough thiamine, but they also, you interfere with absorption of the thiamine. So even if you get enough in your diet, you don't absorb it effectively. And so Wernicke-Korsakoff syndrome is actually a progression from Wernicke's encephalopathy, which includes nystagmus, that's the to and fro motion of your eyes, ataxia, this is inability to walk without falling, confusion, and then eventually that Wernicke encephalopathy can progress to where you get Korsakoff dementia. And that dementia includes permanent damage. So if you catch it in the Wernicke stage and you reverse it either by doing the thiamine supplementation, which you actually have to inject because they can't absorb it very well, or hopefully getting them to stop drinking, you can actually reverse it at the Wernicke stage. Once we get to the Korsakoff stage, some of that damage becomes permanent. We also, so the next vitamin we're going to talk about is niacin. This is used to make NAD, okay? The key things about niacin, and you'll notice these last couple I'm not going to tell you a whole ton about. Tryptophan can also be used to make niacin. Therefore, actually, if you have a tryptophan deficiency, you can end up with a niacin deficiency. Or if you have a diet that's very low in niacin and tryptophan, that's ultimately where you could see this deficiency. NAD is a coenzyme you're going to use in so many reactions in biochemistry, you're going to be sick of hearing them. If you have a deficiency of niacin, it causes pellagra. And this causes a progression of the 4Ds. Dermatitis, once again, that's a nonspecific symptom, diarrhea and dementia. And then if you don't eventually supplement with niacin, you will actually cause death. That NAD is actually vital for so many reactions in the body, you can't go without it. There is a genetic disease, Hartnup disease, which actually causes a defect in the absorption of tryptophan. That can actually lead to the symptoms of pellagra. Okay? Iron, B6, and riboflavin are actually required for the conversion of tryptophan to niacin. So if you get a deficiency in any one of those, you can get this secondary niacin deficiency. You'll also see niacin sometimes used to treat hyperlipidemias. And we'll get into that when you talk about pharmacology. And they use actually pretty huge doses of niacin. And you can really give pretty huge doses pretty safely. The only thing you see is if you give a lot of niacin, sometimes you can get some prostaglandin-mediated flushing, but this isn't really severe compared to, for example, the hyperlipidemia that you're trying to treat. Okay, in the interest of time, I'll save these last few vitamins for the beginning of the next lecture and give you guys your break.